Hello, everyone, and welcome to today's webinar, Effective Denials Management Strategies to Drive Growth. My name is Jacob Emerson. I'm the insurance editor with Becker's Healthcare. On behalf of all of us here at Becker's, thank you so much for joining us today. Before we begin, I'll walk through a few quick housekeeping instructions. We'll begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording at any time. If at any time you don't see your slides moving or have trouble with the audio, try refreshing your browser first. You can also submit any technical questions into the Q&A box. We're here to help at any time. With that, I'm very pleased to introduce today's speakers. Doug Polasky is the Executive Vice President of Sales in the Midwest at Xtend Healthcare, and Colleen Goethals is the Vice President of Mid-Revenue Cycle at Xtend. Doug joined Xtend in 2010 and currently serves as EVP. Doug leads the consulting team and is focused on key account management and mergers and acquisitions processes. He is an accomplished executive with over 25 years of RCM experience, leading people, building teams, and improving workflow. He has a proven record in successful assessment, planning, account management, and implementation of activities which improve or accelerate cash for healthcare systems. Colleen has more than 30 years of healthcare experience, vast knowledge of health information management operations and RCM, and is a subject matter expert on privacy. Her experience includes HIM/Revenue Cycle Regional Director, an HIM consultant, a privacy officer, an adjunct college professor, a speaker, and an author on revenue cycle topics. Colleen is a past AHIMA board member, a past president of the Illinois Health Information Management Association. She's a distinguished member of the association. She's an AHIMA fellow and is NARA certified in federal records management. She's also the recipient of AHIMA's Triumph Award for Advocacy and Policy. Doug, Colleen, thank you so much for being here with us today at Becker's. I'll now turn the floor over to you to get us started.
Thank you, Jacob. Today, welcome everybody this afternoon, and for giving us time to talk about everybody's favorite topic, which is denials management. And if it's not your favorite topic, I think everybody will agree that we're all spending a lot more time than we would like to be fighting these denials. So today we're just going to walk you through our agenda, which includes, we're going to take you through the impact of denials, help you establish a denial rate, help you to know what your denial rate is. Then I'm going to turn it over to Colleen, and she's going to talk about the root causes of denials. We're going to go down a few levels. We'll talk about trends, collaboration that needs to happen within health systems to fight these denials. We'll talk about workflow assessment, writing successful appeal letters. Then, of course, we'll talk about how do we measure successes, how do we know if we're getting better, and we'll share with you some of our sample reports. With that, let's just jump in. So the impact of denials. So 89% of health systems saw an increase in denials over the last 3 years. And I'll age myself by saying, remember when back in the day when we could actually go to a payer or get to a supervisor and have them open up windows to resubmit claims or to reprocess claims, sometimes even over a year old. Unfortunately, in this presentation, we don't have a magic wand to do that. It's getting tougher and tougher to get these overturned, and the windows that we work in are getting shorter and shorter. And as of this writing, approximately 11% of hospital claims are initially denied. And for any of the financial executives that may be looking at this, maybe this doesn't matter to you because all you're really worried about are final denials, which are much lower. But it's a big cause of concern for us that are working in the revenue cycle every day, because everything that we have to do to get the 11% that are initially denied down to the 1 or 2% or less than 1% for final denials, that takes an awful lot of work and rework. And that's one of the worst things that, we can say about, all payer denials is just the amount of work it takes to get them overturned. According to some studies, up to 90% of denied claims are preventable. So that's where we'll talk a little bit about workflow of when we find these, is there something we can do to prevent them from happening again? Another interesting stat, only 35% of providers actually appeal denials, even though, up to 66%, 50 to 60% of denied claims that we see every day, we can actually get them overturned and recover the funds for our healthcare providers. The average denial rate for payers, initial denial rate, is 6 to 13% when we look at individual payers. The better news for Medicare and Medicaid, it's closer to 10%. So we're not seeing as many initial denials with the Medicare and Medicaid products as we are for other ones. And the other thing that statistics or studies have shown us is that 31% of healthcare providers, they use a manual process for managing denials. And that could be because your systems don't talk to each other, there's not a good way of tracking it, or you haven't done the work up front to map everything to let your system help you process these denials and manage them. So the top causes of denials, so probably not a surprise to anybody, it's registration and eligibility. They make up almost 27% of denials. It's not surprising to me because this is where, in scheduling and registration, these are the areas of a hospital that you see the most turnover in. So you're constantly training, retraining, bringing new staff on. And it's such an important role as far as getting, correct authorizations, registration up front. And so it's not surprising to me that most of these errors do come from the front end. It's also followed by missing or invalid claim data, lack of authorization or pre-certification. We'll talk a little bit more the authorization and medical necessity we see down below. When we dig into authorizations and medical necessity, sometimes we're finding a lack of authorization or a denied authorization is really the way it's mapped within your system, where it's coming back from a payer because it was deemed not medically necessary, so they're not granting an authorization. So that's something, if you're seeing a lot of authorization issues, you may want to go down one more level just to make sure that it's really not a medical necessity denial. Of course, there's service not covered, medical documentation requested. That's a big part of the technical denials that we'll talk about a little bit, where we're sending a claim in and medical records aren't going with, and maybe the payer in your contracts don't request it, but they will not process your claims without them. So that's a technical denial that usually can be cleared up by just sending the medical records in at the time. We talked a little bit about medical necessity, untimely filing. With the filing windows getting so tight, particularly with some managed care organizations, you may only have 30 or 60 days to file a claim. And so late charges, things like that, you may be getting a lot of rejections, denials for that because of that untimely filing. Coding also is another issue that pops up, and provider eligibility, where the providers aren't don't have the necessary paperwork submitted to be covered by that payer. So we see a lot of that on the back end when we're looking at these. So some of the factors, I think, for the increase in denials, we're all seeing the same thing, really a staffing crunch, that you're seeing it in the hospitals, but also budget constraints. So as more and more denials come across, you need actually more staff to work them on the back end. So if you're not staying in front of it and trying to knock down those initial denial rates, you're going to have to go manually try to overturn them, and that's going to take staffing. But like I said, in today's hospital and physician practice environment, a lot of these staff budgets are being cut, or you can't find the people to actually do the work. So staff attrition and training is another one. We talked a little bit how we see that on the front end where, the constant revolving door of new people coming in, they have to be trained up to a level to adequately fight these. Then that leads to a growing denials backlog. So, and if your backlog gets too big, then you start picking and choosing which denials should we try to overturn. Could be by dollar type, could be by type of denials. There's lots of different factors, but that goes into, a lot of denials aren't being challenged, and, that's a win for the payers when that happens. The last thing we see a lot of too are technology challenges. So we've done everything, we've gotten the authorization, but somehow it doesn't come across and isn't attached to the bill. And so it could be workflow, but a lot of times it's just one system isn't talking to the other, or it's not getting to the payer, or the payer says they're not receiving it. So these are some of the things that we see in our day-to-day lives when we dig into why are these claims being denied. It's usually some of these factors. Okay, let's talk a little bit about the denial rates. So some different ways. So hopefully most people are taking a shot at how do you track and monitor these. And people that don't, I think you'll be a little shocked or surprised at how many denials you do get on a daily basis. These are what we call initial denials. So simply take the number of zero paid claims by the total claims remitted. We strive for less than 5%, but like we say for initial denials, the national averages are over 10%, and sometimes we're seeing 15% plus for certain payers. Another way is to calculate your claims in dollar rate. So the first method I told you is for the number of denials, but then we also like to take a look at how many dollars are impacted. Certainly we've seen a lot of denials on the outpatient side, but the ones that really get a lot of attention are the very high dollar inpatient claims when you get those denied. So what we do is we take total dollars remitted, total dollars paid by total dollars remitted. So it's just a simple math formula. Take that in, and that will calculate your dollar denial rate. Then you should also be tracking your rate of appeals. Best practice, you should be, any denials you get, you should be fighting 85 to 88% of these. So you should actually appeal these. This doesn't necessarily mean appeal letters, but it just means fighting them. It could be a technical, it could be something else. But, most of these denials, if you can be successfully overturned if you decide to fight them. Sorry, I'm having a technical problem there. So the next question is, we found denials, now what do we do? And typically we categorize them into two different types, technical denials and clinical denials. Technical denials, these are, in the past, we would just call this follow-up activity in your business office. But we're now seeing some specialization with this. And the first thing to do when you start separating these is track the reasons why you're getting these technical denials. Group them by payer, because you'll see different payers are typically, denying for different reasons. And then start tracking them by payer. Like I said, most of it's probably going to be authorization out of network, could be missing wrong codes or modifiers. All of these can start with just a technical appeal. Missing wrong codes, simply, putting the right code, sending it back to coding for a review, or it could be adding the modifier. On a network, you'll probably have to write a letter to appeal that. in authorization, you may have to go looking for the authorization if you have it and make sure that it gets over to the payer. For clinical denials, that gets to be a little bit more work and will involve more people. Primarily, you're going to look at medical necessity denials. So, what happens? Why are they denying this? And this is where Colleen will talk a little bit more. What can we do about it? This is where clinical resources probably will need to help you. It could be a peer-to-peer review. It could be a nurse auditor helping with the appeal letter. It could be other things that you need to do. And if you do have a clinical denials team, it's probably going to involve some of these clinical resources. If you don't have a clinical denials team, you probably need to find out where you can get your hands on, like I said, some of the coders, nurse auditors, things like that, that will help you appeal these denials and, help you out with that process. And you should have a robust appeals letter writing team. And this might mean, samples of appeal letters for different things, because once you start categorizing them, you'll find they usually fall into a pattern. And so it just, helps to have some of these things ready to go when you need them. Then our last point is just consider an outsourced partner. There's a lot of companies, not just Xtend, but there's a lot of people out there that have built, coding, clinical resources, other things that can help take the burden off you so that you can concentrate your people on, number one, preventing the denials, and number two, maybe fighting some more of the technical denials that are a little bit easier to overturn. So denials requiring appeal. So some of the examples, inpatient days are approved. And it's always puzzling to me when you look at, denials for days that are denied. The first day and the last day and some in between are denied, are approved, but then you have 2 or 3 days in the middle that aren't. I don't understand how a payer could come to that conclusion, but it's fairly common. So when you see that happening, you definitely need to appeal that. Service level of care denied for no concurrent authorization. And a lot of times when we look at these, authorizations have been approved, but it may not be for the right thing, or they're approving for something else, or somehow this approval does not make it on into the claim with going into the payer. So those are some of the things when you start looking at these that you can usually appeal and mostly win. Not a covered service, that you may have to bring some of your contracting people into this, or take a look at, is there some changes that the payer is requiring in order to get this paid. A lot of things denied that we see that ultimately you can't overturn is if you're getting paid a bundled fee but you're still charging different things. So that's something, if you are getting a bundled payment, you may want to go back to your charge master, your charge capture, see if you can change things just so that you're not, messing up your system with all these denials that come across. Claim denied for elective service without pre-authorization. This is something that, through strong workflow, you should probably never have an elective service that gets done without an authorization. And that you may need some help from your administration and your medical side, to make sure that all these approvals, because if you haven't gotten authorization, very seldom can you ever get these overturned. So that's something you really, if you're seeing a lot of these, it's really a workflow or a policy issue you need to address. And we mentioned a little bit before about timely filing with the very tight windows. You want to know for payers that have tight windows and maybe put triggers within your system to make sure that you're not going over, timely filing for some of these. Okay, for denials requiring additional information, usually we see this pending receipt of medical records. And I can't tell you how much rework we do at Xtend, and we see our clients work where, the denial comes back that we want to see medical records. Number one, half the time it seems like we've sent them already. They just can't find them. So it's back in the old days, we'd actually have to, send them priority mail and have them, somebody sign for them, because that would be your only proof. But these days, you really want to make sure that you have an electronic record that you have sent them. Sometimes you may have to send them 2 or 3 times until they receive them, but you definitely want to have that tag that you can go back to, because then many times once you send them, they'll then come back and deny you for timely filing. So you want to make sure you have that proof of submission. And or sometimes pending receipt of itemized bill, missing or inaccurate information. So these are a lot of times that we're going to have to go back and have somebody review the notes to see if something else needs to go on, or this could be like the bullet below. It may have to go to coding to address these issues. So the last thing I'll talk about is just data and analytics. So a lot of this, you'll find them people working one by one, but you really want to go through the hard work of, making sure you've mapped your CARC and RARC codes so that you can use your system to help you. It's good that you can trend them by payers, you can trend them by type, and you can trend them by dollar amount. And so that's the first step. Colleen will talk a little bit more about what we do as we get, into the actual claim data, but you want to start off by seeing what are your big problems and how can we handle them. And you want to document and trend the reasons for denials. First, you want to do this so that you can start fighting them on the back end, but then you want to push it forward to see if there's workflow, systems issues, anything else that you can start to, drop that initial 11, 12% denial rate down to 5 or 6%. And then this will help you identify patterns and trends also. Now I'm going to turn it over to my colleague Colleen, and she can take you a little bit deeper into some of these.
Great, thanks, Doug. Yeah, one proactive approach is we talk a little bit about root causes and prevention. One proactive approach is really getting a team together to collaborate, right? Multidisciplinary team that is comprised of various departments throughout the facility. So I won't read all these, but this is what a core team should include, this leadership from these multiple departments within your facility. And I want to stress the physician liaison being very important as well, maybe as an ad hoc, but someone that you can go to, part of the physician. It's interesting that a recent study by the National Association of Healthcare Revenue Integrity revealed that 63% of the respondents, they stated that when they had these interdepartmental committee meetings, they consider that best practice because they were able as a group identify and address the problem solving of denial issues. So it was very popular for them, very best practice, I should say, to have this team. And, meet regularly to identify those root causes, going back to what he said about meeting regularly to permanently correct them. And you might get a little bit of resistance initially from your departments, but that may be because they don't understand what their workflow is. Everyone is so focused on, this is my workflow, how can I be that important? Or what does my doing this or that have to do with what you're doing? And once you start doing those workflows and understand it all of a sudden departments go, oh, okay, I understand now how what I do affects you. So again, looking at that claim workflow from the beginning through all the pieces of the revenue cycle is very critical. So start with the obvious, right? Scheduling. It may even be considered pre-reg might be where you start to get those authorizations and looking for that medical necessity. And as we shared earlier, that Doug, I think, mentioned that sometimes you think it's an authorization issue, but sometimes when you drill down even further, it wasn't that they didn't get an authorization. It was that the payer decided it wasn't medically necessary and did not provide a authorization. It could also be, something did scheduling and surgery scheduling and the authorizations, they go hand in hand, right? So there's one best practice of a facility I spoke to in which the surgery scheduling actually looks at the CPT code that was assigned and compares it to the auth and makes sure there's a match there. And if not, that scheduler is actually going to the provider, discussing it with him prior to surgery, and ensuring that the authorization and the procedure that they match, that they're accurate and thorough. And then make sure then again that it's medically necessary. So if you've got your schedulers working with even your nursing area and your providers, surgery scheduling, all of that, working together, you can help get the proper auth and make sure it is medically necessary. Then you go to patient access. And again, patient access, authorization, accurate patient information even. And when I say about accurate patient information, I always give the example of I had a procedure many years ago, and this is before I was even involved heavily in denials, but I had a procedure done, and it was a female procedure, and the claim was denied. I wasn't real happy to get a bill for $35,000. Once I had to get the billing department of the facility along with the payer on the phone with me, three-way call, and they determined it was as simple as, because I was on my husband's insurance, they had put me down as a male. Something that simple could be the wrong insurance. That's why it's so important to make sure the right insurance is entered. And then also, if it is it potentially not a covered, did the patient receive an ABN? And does your patient access department understand how important the ABN is? Patient access is one of the most critical pieces, scheduling as well, are two of the most critical pieces in this whole process, because we've got to get that authorization or have to understand what's going on from the beginning. And so they're just critical and so important to the whole workflow. Patient care, though, is very, very important as well, right? Physician documentation, getting your CDI involved with your workflow and with your multidisciplinary team. They can see patterns. They will see whether there's ample documentation there needed to pay that claim. And they can work with you. You can see their trends and things like that. And again, this goes back to medical necessity. You've got also, it's very important to include your health information management department and coding areas. They're extremely important to this workflow. You want to make sure that the documentation is complete, that it is timely. You want quality documentation. It's part of that quality revenue integrity and part of data management. And if you do a thorough analysis of that documentation, what was present at the time of coding, and this is of course post-discharge, but what was even there when CDI looked at it, you can find trends and you can educate the providers, you can educate your coders as to what is needed and where their education levels lie. It's also important to note that there is a shortage of qualified coders right now, qualified certified coders. It's made it more difficult to ensure that some of these edits, for example, are caught at the time of coding pre-bill, before the claim goes out. So I've even heard of a lot of facilities looking for bots, for example, or other technology to assist with some of those pre-bill edits and catch them when you can and correct them before that bill goes out. Of course, billing and patient accounts is very important. Doug talked a little bit about the bundling of codes. Make sure your charge master is up to date. I have seen facilities that have not kept it as up to date. Maybe they don't do regular audits on it and make sure that they're up to date and have the proper information. So make sure that that is being done. And then there's coordination of benefits. Make sure everyone understands that. Timely filing, I really don't want to talk about it because it's one of my biggest pains is timely filing. But to earlier what Doug said, you really have to understand which payers have allowed the time to get these appeals. Some are 30, 60, 90 days. Understand what your managed care contracts say and understand what that timely filing is. If you can build that into your system, that's great, because then you won't be, you won't miss something. But again, understanding each and every one of these pieces is very, very critical to the workflow. And then we have additional departments that we want to provide as well. And those are information technology to ensure, I'm trying to, there it is. There we go, technology issues. We want to ensure that your systems are updated timely, review your any kind of interface issues. Remember, we just had a coding upgrade on 10.1. We're going to have some more coming up here with CPT on 1/1 of next year. And that we also are getting even mid-year coding updates now, which in my many, many years of being in the coding world, we've never had before. So since the pandemic, they've added even an additional time frame. So make sure your information systems is aware of these technologies and these updates that need to be done. I'd also then on the side, make sure that your compliance department is involved. Have they performed audits recently on remittance advisements? What about your write-offs? What's your policy say about write-offs? Your zero payments, your registration and insurance verifications. Of course, coding audits is very important to do, as well as your charge master audits. So now that you have determined what your root causes are, another piece of this is having a very robust clinical appeals, appeals writing area. So it's critical that you have this strong team to respond. If you remember that first slide, there's like 35% of facilities and providers who don't even appeal at all. And it's important to appeal those, let's say, easier ones, the ones that don't take maybe so much time. But the clinical denials really get into a more specialized field, as Doug was talking about earlier. We talked about 85 to 88% of denials being best practice, and it's important that you have the right FTE complement to complete those appeals. So again, going back to knowing how many appeals you have, how many require those appeals is important. And then it could take a significant amount of time. Some appeals letter could take a couple hours, depending on what it is. So here's some tips to successful appeal writing letters. Again, let me just stop by saying, before you even decide if you're going to write this letter, make sure you've validated that you even want to write that letter. So not every case needs to be appealed. There are maybe some cases that are not supported, they don't have supported documentation. The best course of action might be not to appeal it and just accept the denial. I know there may be some CFOs out there who's going to say, please try and denial or try and appeal 100%, but there's usually anywhere from a 10 to 12% that you're not going to get back, and you're really wasting important time on those appeals when you know you're not going to win them. We do have some facilities who do require 100% appeals, but it does take a lot of time, and you could be using that time towards prevention or for education instead of writing those appeals. So again, appeal every case where there is that documentation to support the original coding. And, you know, we need to make sure that you keep the letter very, very concise. You want to look at the content. You don't want to put too much information in there. Payers do not want to sift through a lot of information just to get to the point. So keep it very concise. You do want to include pertinent record excerpts that will support your appeal. So use that medical record documentation as content and provide that specific context to support the appeal and how it relates to the reason of denial as well. You might have to even include copies of the medical record where helpful. There are times when you might need to include the operative report, discharge summary, other documentation as part of your argument. So make sure that you reference those documents and include those in your letter. Also very important, if it's coding related, look at the official coding guidelines and include those excerpts as well. It's also important to include the credentials of the people that are involved in that appeal. If you've gotten a lot of people that have helped you with this appeal, you may have had a physician, you may have had nurses, you may have had pharmacy, so on and so forth. Include those names with their credentials in that appeal letter because it goes to credibility and the expertise of those involved. And then you're getting really down to the reasons why you're appealing. And those usually are pretty good wins. I can't express enough how important it is to measure your success, to track and report. This is really critical to a very well-rounded denials and appeals program for both just tracking what's going on and for prevention. I recently spoke with a facility who wanted some help with appeal letter writing, and when I asked how many they get, you know, how many total denials they get, how many do they appeal, they didn't have those numbers. And so once we started tracking that, we could really focus on what was going to get the most bang for their buck, really. You know, where can we really focus on that? And this information is really critical as well to show administration and get their support when you go have this information, again, data, right? When you have that information and you can take it to administration, you can really start talking and saying, look, we had this many denials, we had this many appeals, we didn't appeal everything, and here's why. Those are cases that you can really learn from. You can start working with your physicians and really help educate them as well. You also want to include cases that you did overturn and what the financial impacts are. The financial impact will speak volumes to your CFOs, for example. And everyone you get overturned, you know, some of these people will pay for themselves because you did get them overturned. So it's a really great number to track. You also want to track your second level appeals. There are going to be some that you still disagree, even though it got denied. You may disagree again. You definitely want to escalate those second level denials and appeal those as well. And then it's okay to track your failed appeals. You really need to. You're going to look at what trends there are. Are there, for example, experimental procedures and drugs is on the rise right now, what we're seeing in some of our facilities for denials. And so what is that? Is the facility willing to take that hit because that is an experimental and you want to continue doing that procedure or using those treatments or not? Or is it not worth it because it's costing you in the end? So again, analyzing these trends allows you to educate, but it also allows you to move from management of denials to the prevention of denials, because that's really what we want to get to. We really want to get to the prevention of denials. We're never going to be able to have 0% denials, because as soon as you get really good at figuring out what this denial is all about, the payers come up with another list, right? We've all seen that. But again, having this information, knowing where you can put your efforts is very, very critical. So again, we want to break down the process. We want to identify the causes to let you move forward. And again, once you identify the root cause, improve workflow, and you can provide focused education. I also want to mention that reviewing all these steps from receipt of the denial, routing to the appropriate persons is critical. We often find that during the workflow, maybe the denial isn't getting to the right people and it's sitting on someone's desk or in someone's inbox, right? I mean, we're getting them electronic now, but maybe it didn't get routed appropriately. We want to make sure that you have that as part of it. A recent survey revealed that for each claim that is denied, it takes an additional 21 to 45 days for reimbursement if you get that overturned, right? So the best practice is that you need to work those denials within 48 hours of receipt. That might sound difficult, but again, if you can work that into your workflow, I think that's really important. And make sure that all those tasks as part of the appeal have been addressed, and that you're documenting everything that you should. So, and I also want to share that you really should include and collaborate with your payers. We know of some facilities that have regular payer rep meetings, right? That's wonderful. What we're also finding is there's a lot of turnover with these payer reps. And so you start to get a relationship with one of them, and then they have turnover. But keep trying, right? Building those relationships are good. One facility we even worked with, they have this thing called a work group, a weekly work group in which they meet with their payers. So that's a really good way to get your payers involved and to work with them. And again, I can't speak enough about collaboration, not just with the payers, but also with your different departments who are involved in the workflow and are involved in the day-to-day tasks. Very, very important. And of course, education. Make sure the front end knows how important their jobs are, how important it is to the whole process of the claims and claims approval and a claims denial. That the coding is getting the attention that they need, and then of course the business office, or as they call it, back end. And make sure you have those policies and procedures revised and updated as needed as well. And this will perform continuous improvement to meet regularly. Have one other best practice that I'll share is that they have monthly meetings with utilization management and other parties so that they can communicate these trends and see where they're making headwinds and maybe where they need additional. So basically, in conclusion, before we share a few sample reports, we have consistent and timely review of data. Make sure that you have the right resources up front and that you're tackling these denials in a timely manner and that you're getting down to those root causes. You need to have open and ongoing communication and collaboration with the departments and payers. You want to make sure you understand how to write those successful appeal letters, whether they're technical or clinical denial letters. And then, of course, always measure your success and share that success with administration as well as each of the departments that have a piece into this. I'm going to share very quickly here just a few sample reports. And this isn't based on a large number. But you can see here just a few ideas of the denial reason, how many accounts, what was the account balance, and what percent that is. And of course, always like to put in there a little pie chart because some people don't like numbers but like to look at pie charts. So that's a good way to identify those. You can even break it down by payer. As Doug said earlier, breaking it down by payer will show you a lot of good trends and things like that as well. So break it down by payer and then include those financial impacts as well. Also looking at, the clinical denials and being able to focus in specifically on the areas that might need attention to. Medical necessity, obviously very, very important, and that is the majority that we see and that most facilities see. But again, your authorizations as well that are missing. And that went a little quickly. Sorry, let me go back here. Let's see what's happening here. Okay, sorry about that, technology issues here. We also want to look at clinical validation. I want to point that out, that's important that you are having a team look at that clinical validation, because that's another thing that I just read an article just 2 days ago about clinical validation and how that's on the rise. And you might want to even break it down even greater by payer to say, by payer, what was the reason? So again, getting down to really the nth degree, getting down to almost every penny in every specific area to find out what is happening and what's going on in your area. We had one facility that we found that had a heavy MRI, and it's not on these slides, but had heavy MRI issues, and went back to the MRI department, went back to scheduling, went back to registration, and was able to reduce that over a couple of months. And again, you're talking about, we've got some delays there, so it takes a while to see the real benefit sometimes, but they really got that down because they did that deep dive into the data and into the information. And let's see, we went back one too far. I don't know why this is going through on its own. It's got a mind of its own all of a sudden. But again, we also did the nurse determination of the denied reasons. So which ones did the nurse appeal and why, and those that she didn't appeal? And what are those? Why was there 25 counts that there was no appeal, and do another drill down of those as well. Again, we thank you for your time. Doug and I appreciate being asked to speak on this very important issue. And I think now we'll take any questions. We'll try to answer your questions that you might have.
That sounds great. Thank you so much, Colleen. And thank you, Doug, for that excellent presentation today. Like Colleen mentioned, we'll begin today's question and answer session. For our audience members, you can submit any questions you have by typing them into the Q&A chat box on your webinar console. So, Colleen, Doug, our first question for you both is, how can providers reduce claims denials better?
I think it just goes back to, number one, understanding the data, and then putting those prevention methods into place. Because if you don't understand the data, and I'm real focused on the data for some reason these days, because when you do drill down on the data, you might think, oh, I know it's all medical necessity, or I know it's all authorizations, which statistically 27% says it is. But for your particular facility and institution, it may be a little different. And then continue to drill down. Is it a handful of physicians? Is it one specialty? Is it one particular physician in a certain area that you can do some one-on-one education? Is it a coding issue? So again, I get down to really the data points and starting to prevent these things from happening than having to have so many people on the back end. And as I said just a few slides ago, it takes anywhere to up to 45 days once you've even appealed, and if it gets overturned the first time, to even get payment. So you're reducing your collections there if you're not getting, if you don't stop it before it happens. I don't know, Doug, if you have any other prevention ideas.
No, I agree with that. You have to look at I call it looking at the macro, your reports to see where the denials, what payers it's coming for. And then you need to dive into the micro, actually look at the claims data to see why it's denied, and then, take appropriate action. Then it'll lead you to two things. Number one, seeing what you can do to overturn it. But more importantly, I think, is to see if you can go back into your workflow, technology, or something else, see what's going wrong, fix that so it doesn't happen again, or it doesn't happen until the next time the payers change the rules on you.
Thank you both for that answer. Our next question from the audience: have you considered utilizing procedure videos, digital documentation, which includes procedure codes to collaborate patient care, medical necessity, and compliance requirements?
That I have not heard that. That's a great idea. I wrote that down. I don't know, Doug, if you have any thoughts on that. I think that's a great idea because, again, we've got to keep up on all these different procedure rules and all the different payers and things like that. So it sounds like a great idea if I understood the question correctly. Doug, you want to take a shot at that?
Yeah, I've never run into that. I don't know, as a question, have we ever tried that with payers or just internally for training? My only thing was if we're, using any video or anything for payers, you always have to take into account what the payers want or will accept. And, unfortunately, sometimes they make the rules or, some of the rules we have to adhere to.
Yeah.
That's a great point, Doug. And to follow up with that, how can we better coordinate with payers for process improvement?
Well, and that's the difficult part. So I think it even goes back to contracting. And Colleen spent a lot of time talking about, collectively within, how do we handle this? And so, the first area is obviously the one-on-one follow-up. But then after that, it's your payer meetings. Unfortunately, for a lot of payers, I don't know if you've seen in the audience this behavior, but you start making traction with one payer rep and then they get switched out or they leave. And so sometimes that can be frustrating and take a while. But what I've seen, that's maybe a little more effective is making sure that your contracting department, your managed care department, that they're very involved so that when you do see a couple things that are really adding up, that you take it more to that level. And you may find you have a gray area with your contract that you certainly can, improve upon, the next time that it gets renewed. But also a lot of times these people in your organization, they can help you with the payers saying, it's gray in the contract, but your intent and our intent was for this to happen. How do we, handle it so that we're not using all kinds of man hours, correcting it, and then we're tying up your claims reps also.
Doug, why do you think that they should outsource denials-related processes? And Colleen, this question is for you as well.
Okay. Just from what I've seen, it's really the crunch on, staff of. It's just a way to add more staff to it. And there's actually a very good ROI. So, some people have told me if you look at it, what's the most expensive, cost in your whole revenue cycle, it's your denied claims. It's not the cost of your people that you have collecting. It's how many denials slip through. And when you look at going to a vendor that probably has dedicated coders, designated, nurse type people that can help you with these denials. And some places even have, physicians on their staff that can do this. When I look at my hospital provider clients and other people I talk to, a lot of times they have good intentions and they grab these people, but then they're also the first people that get pulled off for other things, be it to, billing, could be for actually clinical care and things like that. So a lot of times, even if you're able to wrap your arms around those resources internally, you can't always keep them. And so that's why it's a good idea to have a vendor that you can lean on when that happens.
Yeah, and to Doug's point, again, staffing is very critical. As I said earlier, there is a shortage of certified coders out there, so it's difficult to get the expertise of the credentialed coders who can work these edits and who know edits and know how to work them in a timely manner. In addition to that, I was at a presentation a few months ago saying that by 2030, there's supposed to be a 33% reduction in the number of nurses we have. And so nursing is very important, as are our coders, to helping with writing these clinical appeal letters, and yet there's a shortage. And so again, back to the original point, outsourcing can often supplement and assist with that expertise to help the facilities actually get to that letter writing or to that appeal, to get those appeals out there. So exactly what Doug said.
Fantastic. Well, that is all the time that we have for today. I want to thank Doug and Colleen for an excellent presentation and Xtend Healthcare for sponsoring today's webinar. To learn more about the content presented today, please check out the resources section on your webinar console and fill out the post-webinar survey. Thank you all so much for joining us here today at Becker's Healthcare. We hope that you have a wonderful rest of your afternoon.
Thank you.
Thank you.